like to request Dr. DMM F Osmany to deliver his talk on cardiac MRI for myocardial viability assessment.
Bismillahirrahmanirrahim. My respected teachers, my mentors, learned colleagues, and the organizers. It is my pleasure that you have invited me to talk about myocardial viability using MRI as a tool. It was planned to have a case-based discussion. MRI is the learning science in cardiology nowadays, and all the centers in abroad, like Europe and America, they are having a huge MRI centers to assess the viability. The main options of the MRI scan nowadays, while large volume centers, they used to have MRI to see the viability before the interventions or any revascularization. On that ground, I'm Dr. Osmany. I'm from Bangabandhu Sheikh Mujib Medical University. I'm a cardiologist working there. I'm going to present my cardiac MRI evaluation for viability assessment. Before running to the main presentation, I would like to go through some of the short pathological slides with, that will be contemporary to the cardiac MRI, though we already have huge presentation about cardiac MRI viability and other viabilities also. This is a wavefront phenomenon of myocardial ischemic death that we can see within this, starting from an infarct. In 15 minutes, there is a ischemic myocardium, but there were no infarct. Within 40 minutes, there is subendocardial infarct. Within 3 hours, there is mid-myocardial infarct, and within 6 hours, it's become transmural. So this is the case of transmural, what is very important in viability. When transmurality of infarct and the viability of myocardium is very important. Let us see all these three pictures. They have a fibrosis on the top. This is 25%. On the middle, this is 50%, and next one is 100%. In this case, so the transmural 100% is non-viable. It is grossly, you can say. Let us see how does it look like in coronary artery territory. This is an transmurality, LAD lesions, and this is loss of viability from the mid to apical segment. We can see the sparing of the basal segment, but the territory is LAD. And next one, it is an 100% transmural infarct on the LCX territory. And this is an RCA territory. You can see this is 100% fibrosis, and so there is no viability in the inferior wall. This is RCA lesions. So we are talking about the state of myocardial hypercontractility during the chronic hypoperfusion, and in presence of complete viable myocardium, which recovers functionally upon revascularization. This is one answer of the question of myocardial viability from the JACC. JACC also says viable tissue which is hibernating tissue that can define as a dysfunctional myocardium without scar, which recover functionally, spontaneously upon the revascularization. This is an perfusion, the inducible ischemic event after the viability that you might have questions about the revascularization, but today is not that topic, so we'll talk later on in some occasion also. Now come to our cases. This is our case, one of the case. This is the one of the case. He is diagnosed 50 years old male with a diagnosed case of STMI, hypertension, and diabetes mellitus. He had gone through an PCI to LAD with a sort of degree of like LV systolic dysfunction after the successful intervention. But he also had a LV thrombus. He was on warfarin. Now he has a complaint of like black stool. It was not conclusive to apprehend the thrombus, so he had referred to a MRI lab to evaluate the thrombus and LV function. We have gone through all these are the echo images of 4 chamber, 2 chamber, 3 chamber, and you saw the short axis in mid, base, and apical segment. You can see the anterior interseptal wall is hugely akinetic, and apex is mostly akinetic. We have gone through the assessment, quantitative assessment of LV, and the severe LV systolic dysfunction was there. RV was most of all normal. According to the regional wall motion abnormality, you can even check when you have done the LGE, there is increased enhancement in the apical region and anterior interseptal region. This is on the short axis view. We can see there is 100% full breadth fibrosis, necrosis on mid and apical segment. So our CMR finding was severe LV systolic dysfunction. LVF was 28% with normal RV ejection fraction and non-viable territory in LAD, and there was no thrombus. There was the second case. It was a bit challenging because he was 36 years old and had an acute ST elevated anteroseptal infarct in Kumilla and referred to Dhaka Cardiac Center for underwent pharmacological revascularization in the emergency room. His pain was subsided. Next morning, revascularization was assessed by a conventional coronary angiography, which reveals coronary flow in TB4. All coronary arteries except some remarkable slow flow in LAD and minor irregularity. There was extent of dye holding in the proximal LAD. We can see the coronary angiogram here. After 3 years, the patient came to us. Meanwhile, he was more or less normal, except some degree of breathlessness on bricks walking. And he had an experience of sudden fall with acute breathlessness. Patient was admitted with the diagnosis of acute left ventricular failure with post-myocardial infarction, diabetes mellitus with hypertension. They were referred for a cardiac MRI. He was referred for a cardiac MRI. Now we can see the short axis, regional wall motion abnormality on the same area, anterior interseptal wall in 2 chamber, 4 chamber, and 3 chamber. There is mostly akinetic areas, and the apex is completely akinetic. We have done the LGE. You can see there is sparing of the basal part. There is 50% of LGE in basal part, anteroseptal area, but mid and apical part is totally white. The patch is there, so it is 100% LAD is fibrosed. LAD territory is fibrosed. And we can see the 3 chamber, 4 chamber, and 2 chamber, and you can work out there's huge white patches around the anteroseptum in mid, apical, and apex. So the severe LV systolic dysfunction, LVF is 27% normal LV function, and it is 61 and non-viable territory in LAD. I would like to conclude my session with the reference of the circulation. They said, make a better trap, mouse trap, and this mouse trap means enhancement. So let us do some enhancement and supplement the interventions. If there is any regional wall motion abnormality, we'll go for an LGE. And if there is no LGE, go for a revascularization. And if it is LGE there, then go for an transmurality. If it is more than 50, you don't need any revascularization, go for a medical therapy. And rest of them we can do and low dose vitamin stage MRI, that's said by Ajoy. And if it is there is induced ischemia, we can do the revascularization. Thank you. I have no disclosure of interest, and I had huge thanks to University Cardiac Center, BSSMU, Zurich University Hospital, and Sarawak, Malaysia, and IPID Foundation to giving me a chance to learn MRI and present here. Thank you very much.